International Speaker Forum, and this was started by Simao, and now we are spread over to most of the International Speaker Forum for international. Everyone, today we are meeting at 1:30. This is a Saturday meeting for international weekly sessions which are happening over the period of time. This is a 94th International Speaker Forum, and this was started by Simao, and now we are spread over to most of the countries. So I would name the countries who have been participating on a regular basis. It's Australia, Bangladesh, Cambodia, Hong Kong, China, India, Indonesia, Japan, Korea, Macau, Malaysia, Myanmar, Nepal, New Zealand, Pakistan, Philippines, Singapore, Sri Lanka, Taiwan, Thailand, Canada, US, UK, Brazil, South Africa, and Sweden. And I would invite Dr. Veena Agarwal, Trustee for Heartcare Foundation of India, to invite the special speaker for today. Over to you, Dr. Veena.
A good day to all of our guests from a very wet and cold day in Delhi. I'm Dr. Veena Agarwal, for those of you who don't know me, Trustee of the Heartcare Foundation of India, which was started by my husband, Dr. K.K. Agarwal, the former president of SIMAO, from 2019 to May 2021. It was under his leadership that these weekly meetings were started to discuss, learn, and share information about COVID from the various countries having representation in the organization. We are pleased to have conducted more than 95 sessions, weekly meetings since then, thanks to the very enthusiastic and willing participation of all the national medical associations and their representatives. The strength of this platform is on display here with a guest speaker of the magnitude of Dr. Soumya Swaminathan, principal scientist of the World Health Organization, who has consented to grace this meeting with her wisdom. It is said that there are three essentials to leadership: humility, clarity, and courage. These qualities perfectly define a very special guest today. She not only embodies humility and gentleness, but has full clarity of the problem at hand and the courage to stand steadfast and committed in the face of such confusion and chaos that the world has witnessed since the pandemic started. Dr. Soumya Swaminathan is the chief scientist at the World Health Organization since March 2019. She's a pediatrician from India and a globally recognized researcher on tuberculosis and HIV. Having over 3 decades of experience in clinical care and research, Dr. Soumya has worked throughout her career to translate research into impactful programs. A Deputy Director General of the WHO from October 2017 to March 2019, Dr. Soumya was Secretary to the Government of India for Health Research and Director General of the Indian Council of Medical Research from 2015 to 2017. During her tenure, she focused on bringing science and evidence into health policy, making and building research capacity in Indian medical schools. She has published more than 350 peer-reviewed publications and book chapters and is an elected fellow of the US National Academy of Medicine and a fellow of all the 3 science academies in India. Her vision is to ensure that the WHO is at the cutting edge of science and is able to translate new knowledge and meaningful impact on the population health worldwide. Dr. Soumya's contributions have won her numerous accolades during her illustrious career, the latest of which is the prestigious Tamil Nadu Chief Minister's Special Award for her impeccable role as COVID-19 advisor in 2020. Napoleon once said, "A leader is a dealer in hope," and Dr. Soumya, representing the World Health Organization, offers just that to all the scientific communities across the world, a ray of hope at the end of the tunnel. A very warm welcome to our platform, Dr. Soumya, and heartfelt thanks for accepting our invitation for this same.
Thank you so much, Dr. Veena, for those very, very kind words. And let me pay my tribute to Dr. K.K. Agarwal, whom I knew well and with whom I had many interactions, especially when I was the DG of ICMR. And he obviously leaves a lot of legacy behind. And I'm glad that this forum is being continued and it will keep his initiatives and his memory alive. So what I would like to do today, perhaps, is to go over some of the recent updates on COVID-19, particularly with Omicron. Obviously, that's what is sweeping the world just now. And I'm going to try and share my screen to make a presentation. And then, of course, we can have question and answers. No, I think I'm sharing the wrong screen. Okay, I need to put this in a slideshow and then it should be all right.
Presentation view. Yeah.
And yes, is it okay now?
Absolutely.
All right, great. So let's start with the epidemiological situation. And, as you know, WHO has countries reporting data to us on a regular basis. And we update our weekly epidemiological records every week. You can find this on our website. And you can see here from last week's report, the number of cases being reported on a weekly basis. If you see, even the scale of the graph had to be changed, the y-axis, because we had close to 18 million or over 18 million cases reported. And we know that that's just the tip of the iceberg because of the limited testing. So you can see that from the previous peaks where we had like 4, 5, 6 million a week, it's really gone the growth is extremely explosive. Now the deaths are shown in the black solid line. And you can see that, the peak of the deaths were actually in last year in 2021, particularly with the Delta waves. But the deaths have been fairly stable at about 45,000, 48,000, 50,000 a week. Now, since October of 21, the global death rates have actually stayed fairly constant. I mean, there was a slight decline, and then you can see that the deaths are increasing now again. And yesterday's data I was looking at, there were almost 10,000 deaths again globally just in one day. So the deaths are beginning to climb. Cumulative cases and deaths, again, you can see the numbers here, but these are all underestimates because the true numbers, neither of infection nor of deaths, are actually known, and one has to estimate these. And then we split it by region. You can see that different regions have actually behaved in different ways in terms of the peaks and waves that we've had. India and other Southeast Asia countries are in the Southeast Asia region. You can see the Delta wave, last year, and now the Omicron wave that is in full swing. Africa is the one region where the cases declined last week. All other regions had some increases in cases, but Africa started the wave earlier, and so they've started to see the decline. And the decline also seems to come faster than the previous variants. Now, if you look at the variants of concern in the last 30 days, and you see that, as you know, we have 5 variants of concern. And it also depends on the amount of sequencing that's being done in countries and the type of sequencing that's being done. So in some countries, like the UK, right from the beginning, they've had a large proportion of cases sequenced. But in the majority of other countries, like there's less than 1% of cases actually that are sequenced. And also the sequencing strategy of countries, like if you're focusing only on travelers or if you're focusing on certain high-risk groups, you may get slightly different varying results. But what this slide actually shows is that over the last few months, if you look, yellow was the Delta. So clearly Delta was predominant globally in all countries that were sequencing. In some countries, you can see that there were other variants also earlier, which all got overtaken by Delta. And then you see in the last 2 months, the green, which is the Omicron, absolutely rapidly taking over. And today it is globally accounting for over 99%. So if you look country by country, there'll be some variations. and particularly Latin America has had other variants circulating, like Gamma and Mu. And this again is a prevalence of Omicron. Now you see large areas of gray. Many of those countries actually are not sequencing at all or very minimally. But in countries that are sequencing, you can see that Omicron is predominant. So there's no doubt about that. What do we know about Omicron? So if you look at something called serial interval, which is the time between one case and the next, it looks like there is a reduction in the serial interval. And this has come from some of the contact tracing studies, which looked at Delta, looked at Omicron, and it looks like it may be 20 to 40% shorter than the Delta. And this is why you see very quickly somebody in the family gets infected, and then within a couple of days, you'll see other family members or other contacts getting the infection. Again, when we look at the transmission, the capacity for transmission, or looking here at the change in the RT of Omicron relative to Delta by region, and this is based on data in GISAID, which is a platform that has these sequences. We see again that there's a tremendous increase, 200, 300%, or even in Africa, they reported over 500% increase in the relative RT compared to Delta. So clearly it is more transmissible, probably in the region of 3 to 4 times more. So if we can summarize that Omicron is now nearly present in all countries, rapidly replacing Delta. Levels of transmission are higher than ever seen before, with substantial growth advantage over Delta, largely driven by immune evasion. There are other properties of this virus. One is, of course, the increased binding capacity, because it has now found another way to bind to the cell receptors. The second is the immune evasion capacity, because of the mutations combination it has. It's able to evade both natural immunity and vaccine-induced immunity. And the third is that it could be more in the upper respiratory tract. It prefers staying in the upper respiratory tract, so it could be even easier to transmit. What we are observing is that overall, at the population level, it is of lower severity. So there's a lower proportion of hospitalized patients and lower proportion of deaths compared to the Delta variant. But because you're seeing these numbers, tremendously high numbers, there are increases in hospitalization. Many countries' health systems are getting overwhelmed, particularly since many healthcare workers are getting infected and then they're out on isolating. And then we'll talk a little bit about vaccines and their effectiveness, but definitely the effectiveness against severe disease is preserved to a larger extent. The effectiveness against actually getting a breakthrough infection is quite low. Let's talk a little bit about public health and social measures, because there's always a huge debate, and this is where there's always a lot of confusion about what measures should be put in place or should not be. Essentially now, over the last 2 years, we know that there are many what we call non-pharmaceutical interventions. These are at the individual level, like wearing a mask or washing your hands, respiratory hygiene, maintaining distance. And there are societal interventions, obviously, where you try to reduce the interactions of people. Now, this goes all the way from no restrictions to extremes like lockdowns. What we do know is that these need to be adjusted based on the situation at the country level. And you have to balance the livelihoods of people, the economic impact, with the transmission of infection and its health impact. One thing that we do recommend is that communities should be engaged, they should be consulted, so that they understand why certain measures are being put in place, for how long, based on what criteria, and when will they be adjusted, etc. And there are also countries where some measures were relaxed for people with vaccine-induced immunity or natural immunity. This was done basically to limit the economic and social hardships. But again, with Omicron, we know that even if you're vaccinated, you can get a breakthrough infection, and the vaccines are not actually that's successful in preventing infection. So again, one has to think, it's not, so we cannot take it for granted that because you're vaccinated, you're going to be protected, and therefore you can drop all the other measures like wearing a mask. And of course, then there are things like mandates, vaccine mandates, etc. And we have guidance on all of this because it involves a lot of both technical but also ethical considerations. Now, masks have been found over a period of time to be really a very important part of a comprehensive strategy of measures. Again, masking alone is not sufficient, and therefore that's why we keep saying do it all. And the Swiss cheese model is often quoted as, you know, different interventions. If you add layers of intervention, they're more likely to be effective. So again, trying to maintain the distance, wearing a mask. Again, the masks, both the fit and the filtration are important. And WHO did come out in December 23rd or so with new guidance for mask use, both in communities and among healthcare workers. Among healthcare workers, wherever possible, an N95 is recommended, but a surgical mask can be worn if N95 is not available. But certainly wherever healthcare workers are exposed to situations where there could be generation of aerosols, because that is where the risk of transmission then becomes very high. Even if you're a little bit away from the individual, there's aerosolization. There's been a lot of discussion about transmission of this virus. And again, there are multiple modes of transmission. So it's not either this or that. There's been traditionally a division of droplets, which are the larger particles considered to be over 5 microns. They fall to the ground relatively rapidly. And that's where the physical distancing of 6 meters came from, because majority of them fall to the ground than that. But then you also have particles of all sizes that escape when you're talking or singing or shouting or coughing. And therefore, it's very difficult to have this type of a binary definition where, you know, you have droplets, but we know now that you also have aerosols, which are smaller particles which can stay afloat in the air for some period of time. And that also depends on the ventilation. It depends on the humidity in the room, the temperature, how long these particles stay afloat. And therefore, even if you're at a distance away, more than 6 meters from an infected individual, you can get infected if you're sharing that space for a significant period of time. So that is why the importance of masking in indoor settings, well-fitting masks, and the importance of ventilation. Both of these become very important when we are talking about indoor settings and how to limit the infections, and probably likely to be true for other respiratory infections as well. So going forward, I think one has to pay more attention to ventilation, both in hospital healthcare settings, as well as in other settings where people gather, where there's air conditioning. One needs to make sure that there are enough air exchanges per hour. I think our benchmark minimum is 6 air exchanges per hour, and one has to ensure that there is fresh air that's being brought in, and filtration. All these things are expensive, but then that is the only way to limit transmission of infections which can be airborne. So we are actually looking at now at all infections that are spread, respiratory pathogens, viral and bacterial, to really get a better understanding of the transmission of these infections. And we're involving not only physicians, but also experts in aerosol transmission, which include biomedical engineers and people like that, who have done a lot of research in the last 2 years, really on how respiratory viruses, particularly SARS-CoV-2, but this would apply to others. And some pathogens may prefer droplet transmission. That is, they are larger droplets. You have to be in close contact. For SARS-CoV-2, again, the majority of transmission, we believe, occurs when people are in close contact, because then you are exposed to direct exposure to the particles, as well as the indirect, the smaller particles which you could breathe in. And then, of course, you have also the third mode of spread, which is that if you touch something or somebody goes and you pick up the virus on your hands, and then your hand goes to your mouth and your face, etc., then you can directly transmit the virus into your respiratory tract. So this is why we need to ensure that all of the different preventive measures are followed, because we believe that the virus does follow all these modes of transmission. And then we have as I said, the guidance on what kind of masks, what are the standards, how they should be made, how they should be stored, how they should be used, cleaned, disposed, etc. Moving on to the clinical management, the care pathway starts with confirming the infection, assessing the symptoms, risk factors is very important, and severity assessment, and then you provide appropriate care and treatment, and then evaluate the clinical response and recovery. So this is the care pathway. And as you know, from the beginning, we've had the severity classification, which gives you, the baseline risk. Obviously, the death and the mortality varies by the severity. And so you have the non-severe, and then the severe with oxygen saturation less than 90% on room air, or pneumonia or respiratory distress, and then the critical, which requires life-sustaining treatment, which needs high-flow nasal oxygen or sometimes invasive ventilation. So we've been doing the updates on the therapeutics based on the systematic reviews of the literature. So we have what we call the living guidelines, which get updated every time there is new evidence. And of course, it's a process. So it takes a few weeks from the time that the full data set is available. And we've been quite fortunate that people have been willing to share their data sets, whether it's companies or whether it's academics, so that we can combine them as many trials as possible into doing a systematic review. And then the guideline development group sits down and makes a decision based not only on the efficacy and the safety, but they also look at what are the benefits, availability and access, the ethics, the cost, etc. So the latest guidelines updates are for the use of baricitinib in severe and critical COVID. As you know, this is an oral tablet available as a 14-day treatment course. It could be an alternative to these IL-6 inhibitors, which have to be given IV. And then there's also a recommendation for the use of sotrovimab in people who are at high risk, who are with non-severe COVID. It's an IV infusion given in a single dose, and it can prevent the progression of disease. Again, most of the other monoclonal antibodies have been found to be not very effective in Omicron, except for sotrovimab. So, and the AstraZeneca one, the combination, we still have to get more data on. We will be coming up with the guidelines on molnupiravir. It's likely to be a conditional recommendation. For high-risk patients, you have to exclude children, pregnant women, because there is some genotoxicity risk involved. We also need to monitor resistance in the community, and we need an active pharmacovigilance program. So there are a lot of conditions around how molnupiravir should be used, and it should not really be used widely in the community till we set up these systems to monitor both the safety as well as the emergence of resistance, because as you know, viruses can very quickly become resistant, especially when a single drug is used for treatment. Right now, we're also looking at the combination nirmatrelvir ritonavir, that is Paxlovid from Pfizer. So there will be the group that will meet on the 7th of February to review the data and make the recommendations. We're also looking at fluvoxamine. There's some clinical trials which have looked at that, at heparin, different doses. And we keep on looking at the previous drugs also, like remdesivir, like ivermectin, others, wherever there is new data coming, if it needs to be updated, it gets updated. Then, so I told you these are the living guidelines, and the 8th version was just last week, and now it has 14 recommendations, including 3 new recommendations. There are 2 Janus kinase inhibitors for which there is a recommendation against, I don't remember the names, yes, ruxolitinib and tofacitinib. So there is a conditional recommendation against, and you can see that for some of them, it says it should be used only in the context of clinical trials, like ivermectin, like even for convalescent plasma, etc. And then you have strong recommendations. You have corticosteroids, which still stands. It was the first one. It continues to be very highly effective and recommended. IL-6 receptors blockers, and then now the baricitinib. And then you have the other monoclonal antibodies, which have more weak or conditional recommendations. Moving on to children, we've seen from the beginning that the global cases that have been reported have been less in children, and if you look at age-wise, then at least in the less than 5 years, and then 5 to 14 and 15 to 24 years. So you can see the proportion there of global cases and the number of deaths. We have this reporting system on cases and deaths, and then we have also reporting for clinical. We have what is called the WHO clinical data platform, and that's we encourage countries, doctors, hospitals to report cases, because that's the way we can learn more about the clinical manifestations of COVID. So if you look at the proportion of deaths, then in children under 5, 0.1%, and also 5 to 14, 0.1%, slightly higher in the adolescent age group, but still extremely low proportion of the total global deaths have occurred in children. And this is why we say that children are at much lower risk of getting severe disease. They do get infection as commonly as adults, but very rarely do they end up with severe disease. So what about vaccination in children and adolescents? There are still studies that are undergoing the risk-benefit assessment. As I mentioned, children can get infected and transmit the virus. Adolescents with underlying conditions are at higher risk. So if you look at youngest children, lowest risk, but again, those adolescents, particularly with underlying hematological conditions, heart, lung conditions, they should be considered at highest risk, and they should be vaccinated at the same time as adults in high-risk groups. Now, we just I will talk a little bit more about our guidelines, because just yesterday, our strategic advisory group has updated the guidelines. But just before that, to give you a global picture, still there's a lot of inequity. If you look at the coloring on this map, you'll find less than 10% of people in many low-income countries have received 1 dose, whereas in many high upper-middle-income countries have received at least 50%. And as globally, 60% of the world's population has received at least 1 dose. And India, of course, has done very well. I think over 90% of adults have received at least 1 dose, and at least 60% 2 doses. We're getting close to 10 billion doses being administered globally. So this is really an incredible achievement within a year, but we still have to do a lot to cover up the inequity gaps. Now, this is a slide which shows vaccine effectiveness studies from 4 countries, UK, Denmark, Canada, and South Africa, looking at 4 vaccines, mRNA vaccines, the Pfizer and Moderna, the Ad26, which is the J&J, and the AstraZeneca. And if you look at the top graph here, you can see that the darker squares are Delta, and then you have the lighter ones, which is Omicron. So after a 2-dose schedule, and these are weeks since the time the person has received the 2nd dose. So if you go to, let's say, 25 plus weeks, that's after 6 months, the vaccine effectiveness against Omicron is extremely low. Now here we're talking about symptomatic infections. And then after you boost with either Pfizer or Moderna, you'll find that the vaccine effectiveness goes up, both for Delta and also for Omicron. It goes to about 80% or so. Now again, the follow-up is only till 10 or 12 weeks, so we don't know the duration of how long this booster will last. This is with 2 doses of Chadox, that is AstraZeneca, with an mRNA booster. So again, if you look at over 6 months, even from the beginning, you find that the efficacy against symptomatic infection is lower, much lower for Omicron than it was for Delta, and by 6 months it disappears. But this can be boosted with an mRNA, and then you're back up to about 60 to 70% efficacy here. And then again, this is data from Denmark with Pfizer and the Moderna, again showing that over a period of time, your vaccine effectiveness against infection is going down much more dramatically with Omicron than with Delta. Now, there is, against hospitalization and severe disease, there is more protection, but again, the duration of protection after boosters is not known. So what we recommended yesterday, what SAGE recommended for countries, and of course countries make their own vaccination policy, we give the guidance on the principles to be followed. So we recommended that if you have a low rate of primary series coverage, then among high-risk groups, you should first achieve that coverage. So who are the high-risk groups? They are the older people above 60, they are healthcare workers, and they are people with underlying immunocompromising conditions. And when countries have achieved a moderate to high coverage in the high-risk priority groups, then you can start using the vaccine supplies to provide boosters to those high-risk priority groups, even before offering vaccine doses to low priority groups. So what I'm saying is that if there are limited stocks of vaccines in a country, our goal, what is the goal of vaccination? First goal is to prevent deaths, to minimize the number of deaths, to protect the health system, because we don't want hospitals to be full of patients, sick patients. We want to protect our health workers as well from getting sick. Then you want to start opening up the economy. So you want to, have the impact on transmission so that economic activity can restart. And ultimately, of course, the goal is to control this infection. And right now, these vaccines that we have, particularly what we've seen with Omicron, are still very good at protecting against severe disease, but not so good at protecting against infection. So we have to wait for the next generation of vaccines, which will include nasal vaccines and other vaccines, which will provide better protection against infection. Then we can start thinking about the control part of it. So right now, I think we are still globally at a stage where we have to focus on reducing death. And the unfortunate thing is that in many countries, including high-income with supplies, there are large groups of people who have not been vaccinated. In some countries, up to 30-40%, including the elderly. So the focus of every country should be first try to have as high coverage as possible in the high-risk groups. And if more than 6 months have passed, then start the booster program for those high-risk groups to protect them again because of the waning immunity. Because there are 3 factors here. There's the time since vaccination, and we know that neutralizing antibodies do drop, but T-cell immunity is preserved, which is good even with Omicron. The T-cell epitopes have not been mutated. So that's why we have some confidence that the vaccines are still working well. The second is the type of vaccine that you've received. And you can see that there are differences in the vaccine effectiveness between vaccines. We need more data on the other kinds of vaccines that are being used globally. We have, only mostly the data is coming on mRNA and AstraZeneca vaccine. Third point is your age, your underlying morbidities, what is your immune system like? And then is the variant. And we've seen the difference between Delta with the previous variants and now Omicron against Delta. So all these factors play a role in the protection that is offered. And that's why it's quite complex. It's not black and white because it varies from person to person. But in general, we can say that the high-risk groups are the ones who are at highest risk of death and therefore need to be protected. So this table actually shows how a country might think about having a program starting with the highest risk group. So when you are still at this stage of vaccinating this group, you would give them the primary series and a booster. And as you cover more and more this high-risk group, then you go into the next group, which is the adults with comorbidities, the pregnant women, teachers and other essential workers. Then there are other disadvantaged socio-demographic populations in different countries. These could be prisoners, there are people in homeless settings or in care homes, etc. Here again, we've said that as soon as you manage to cover this highest risk group, move into this group, and they also might need a booster 4 to 6 months after the first course of a series. And then you go to the medium risk, which is the remaining adults and children and adolescents with comorbidities. Again, we're recommending primary series plus booster. And in the lowest risk group, which is healthy children and adolescents, that is children above 5, so 5 to 12, 12 to 17, we're recommending the primary series, but at this point, there is no evidence that a booster will be needed, and we don't know at what time and if at all it's going to be needed. So then the other recommendation that was updated yesterday was on Pfizer, reducing the age of eligibility down to 5 years. There's a reduced dosage for children 5 to 11, it's 10 micrograms, and for 12 to 17, it's 30 micrograms. And then you have the, for the booster for using Pfizer, again, it's the same, start with the highest priority risk groups, 4 to 6 months after completion of primary series. And the objective is restore the vaccine effectiveness of the 2-dose primary series. And we will keep updating each individual vaccine product as we get data from the companies. So finally, I'd like to conclude here by saying that our plan again is a multi-sectoral sort of a plan. It's comprehensive because we have to focus on 2 things: reduce the deaths, severe disease, mortality, morbidity, hospitalization by increasing vaccination coverage and following all the public health measures. And then on the other hand, we want to keep transmission low, because we know that if you allow transmission to increase, you'll also increase the chances of future variants. And so this is why countries need to put in place measures which will control transmission, at the same time avoiding lockdowns and avoiding things which really damage individual and societal functioning. I just wanted to mention that we have set up this mRNA technology transfer hub. It's been set up in South Africa. That's the hub. And from there, we will be transferring technology of mRNA vaccine, how to make an mRNA vaccine, to countries which have already applied to us for receipt of this technology. And hopefully we can therefore expand manufacturing capacity around the world, because we've seen that manufacturing of drugs, diagnostics, vaccines is limited to few regions, few countries, and this actually has impact on global equity. So we need a collective response. It has to be not only at the national level, but at the global level. There needs to be sharing of data, of surveillance, as well as some sort of a global agreement on decision-making. We need to still focus on the implementation of public health social measures. It's too early to lift restrictions completely. So again, there's that balance always, but there are some things like mask wearing, which are very low cost, low risk, if it can be continued for some time, as well as individuals, still being careful about mixing, about mass gatherings, crowded places, etc. We need to continue to support research on vaccines, therapeutics, and diagnostics, because I haven't spoken about diagnostics, but I must say that there's also a huge shortage of diagnostics and of testing in many countries. And that is one reason why the numbers are so varying from country to country. It really depends on how much you're testing. We do have a benchmark of 100 tests per 100,000 people per week, and that is not being met in many countries. We need to strengthen our workforce, build that resilience into the system, because we know how workforce has really been overburdened during the last 2 years. And we need to continue to prioritize opening up of educational institutions, of schools. We have said from the beginning that schools should be the last to close, the first to open, because the kind of downside, the risks of closing schools, the kind of impact that it's having on children is not commensurate with any of the benefits of keeping schools closed. And we've seen in many countries, including India, where schools were closed for a long period of time, that the seroprevalence in children is as high as the seroprevalence in adults. So it did not prevent children from getting infected. It only prevented them from having access to education, to social support, to nutrition, etc. So we really need to prioritize within a country what should be closed, what should be open, where should there be restrictions, etc. Because we have to minimize the damage and maximize the benefits. So I've come to the end of my my presentation, and I'll turn it back to you, to Saurabh, to continue with the session. Thank you.
In presentation. And I would like to highlight the presence of Dr. Heidi Stensman from World Medical Association and Dr. Chong. He's a chair for CIMAO. And I would like Dr. Chong to invite and chair this session along with Dr. Heidi. And we will open the forum for question answers. Dr. Chong, let's take it forward now. You're muted. Oh, sorry, I forced mute. Sorry, I didn't realize that. Okay, yeah.
Thank you very much, Dr. Swaminathan, for your lovely talk and for gracing this occasion with your expertise. Can I just open the? I'd like Dr. Steinmarin to say some words, please.
Thank you so much, and thank you for this talk. I made several notes during the time, and there are several very crucial points that you make here. We are very, very thankful in the medical community that you do this work, first of all, and especially in science, so we can follow it tightly. We're all very engaged. My notes during the time was due to vaccination and also testing, of course, but also the new medications that are antiviral medications that are on the market in limits of the protocols, of course, but are coming to the market. Do you see so the use of the antiviral medications that you mentioned, are they, do you think they will be in a big scale available, or will we have the same problems as with vaccines, with a lack of distribution and access due to both costs and distribution lines? Will we have the same problems and even worse problems with that? Do you see that? And there might be a little bit off because it's due to pricing, but I'm in the forefront. We are very eager to know your opinion.
Yes, that's an excellent question, Heidi. And as you know, WHO has been concerned about access and equity of all products, not just the vaccines. So what has happened is that both Merck and Pfizer have entered into an agreement with the Medicines Patent Pool for sharing of the license for making of these drugs. So for molnupiravir, for example, there are already at least a dozen companies around the world, including in India, generic companies that are manufacturing it. And for Paxlovid also, the licenses have been shared. And so we expect that there will be wide access to these drugs at affordable cost. Of course, there are geographic restrictions that these companies place when they do the licensing. So in the case of molnupiravir, I think it's 95 countries, and for Paxlovid, it's 105 countries, something like that. But which includes all low and low middle income countries. So there are some upper middle income countries that may not be able to afford it and so on. But anyway, that's the licensing arrangement. So as far as possible, we try to ensure, and we really encourage companies to enter into these type of licensing agreements so that there can be broader access. So far, none of the vaccine companies have done it, but it's good that for these oral antivirals. The issue with molnupiravir is that it has some questions around both the toxicity, but also the emergence of resistance. And that's why we are being a bit careful, saying that there needs to be a monitoring system in place before this is widely used, because very quickly we might end up in a situation where the virus is resistant. So we need more studies. We need also combination trials, I think, combining antivirals to reduce the incidence or chance of resistance. The Paxlovid data obviously shows higher efficacy. Molnupiravir was about 30% and Paxlovid about 90% efficacious in preventing deterioration. So it appears that drug may be better, but again, unless we start using it under monitored situation, we won't know fully.
Thank you. Thank you. I have a couple of other questions, but I guess the floor has more questions.
Thank you, Dr. Steinmarin. Can I just get a question from Dr. Akhtar from South Africa? He's been in the midst of these, Omicron explosion. So, Dr. Akhtar, can we have your question, please?
Thank you very much, Chair Dr. Chong. And also, thank you so much, Dr. Swaminathan. Excellent presentation and update from World Health Organization. I have few query and question which bothering. What is the role of WHO on the world leaders like Boris Johnson, who are announcing in the parliament, no mask, no PCR testing, even the school children must not wear masks. Then he's also coming up with this mandatory vaccine. Is it not a violation of human rights, ethics, rules, and law on the mandatory issue? How he is coming up? Because it's a lot of challenges here. The other one is, what is the rationale of the 4th, 5th, 6th wave? How the scientific way we can say this is the way this will keep coming? And the last one, what is the role for WHO anti-vacciner group? Are they getting more stronger than the scientific presentation and scientific evidence? Those are my concern. Thank you, Dr. Swaminathan.
Thank you, Dr. Hussain. Excellent questions. I will try to respond briefly to them. The first one around political decision-making at the country level. Well, what WHO can do is to make recommendations and guidelines based on the best available evidence to us. And of course, we keep on changing and updating as the evidence changes, but it's really up to countries to decide what they want to do within their own national borders. It would be nice, of course, to have some kind of global consensus and for all countries to sort of follow the same path forward, since this is a pandemic. But clearly, the jurisdiction of each country lies within its own boundaries. They can do whatever they feel is best. Context is and so all we can do is advise on what we think is the best way forward. In terms of future waves, I think that there is a lot of discussion going on now. There's one group that thinks that Omicron is the last variant, that we're going to come out of the pandemic. We are not convinced that that is the case. We believe that there will be more variants of concern emerging. We have to be watchful. We have to do everything possible to keep transmission low. We shouldn't give the virus an opportunity to mutate further. Unfortunately, it is growing very rapidly right now. And hopefully, what I hope will happen is that there will be enough immunity at the population level because of vaccination and because of previous exposure, that we will be able to withstand future waves, that it won't cause the same kind of crises situation it caused in 2021. The COVID virus is here to stay. I think that's absolutely clear. It's not going anywhere. It will move into a stage of endemicity, which means that it's there, it's everywhere, it infects people. There could be peaks, and now people talk about seasonal. This virus has not been seasonal in the sense it's come in the summer, in the winter, in all seasons. So it's not behaving like influenza in that sense. But what could happen is that every time it mutates and it causes a new strain, maybe there will be a localized epidemic or an outbreak. And this again will depend on many factors. So it's very hard to predict, but the severity of the pandemic should definitely reduce in 2022, but we are not out of the pandemic. And that's why we feel it's premature to sort of lift all restrictions and say everything is over with Omicron. It's not going to be, and we shouldn't fall into that trap. On your third question of vaccine mandates, it's a big debate. And in fact, we have a very nice guidance that we produced. Our bioethics experts got together and they have come up with a publication on ethics of mandatory vaccination. So there are situations where it could be needed and it could be done. But I think we lay out when such a situation may occur, what would be the public health considerations versus individual rights. And we need a very good debate on this before a decision is made on mandatory vaccination. And it should be limited only to some groups, and it should be clearly justified. And then finally, your question on anti-vaccine misinformation, all that is very important. Again, WHO has started a big program of work on how to tackle misinformation. It's a challenge, it's not easy, but we do it in a multi-pronged way. Firstly, by providing as much information as we can, credible information, easy to understand to the public. And secondly, to work with the big tech companies, particularly the social media platforms, to try to reduce the amount of misinformation that is spread through those platforms.
Thank you, Dr. Swaminathan. And can I have Dr. Bukhari with his question, please?
Thank you very much, Chong, and thank you very much, Swaminath, for giving the update and nice presentation. Your shorter clips are very popular in Pakistan. I am Professor Bukhari from the Pakistan, but it is my first time interaction with you. My first question is that the transmission, the spread, the symptom, and the outcome and the management of this Omicron is different as compared to the all previous variant of concern. Why not the WHO change the name from COVID-19 to COVID-21, or from SARS-CoV-2 to 3? Because not only there are 50 mutations and one insertion, especially 27 in this one. This is my first question. The second question is that, do you think this is a biological control, and this will, the Omicron will finish all other variants, and it will act like a natural vaccine? Because we are looking in Pakistan from the last 2 weeks, no doubt the data is raised about 10 times, but people are coming and going within 3 days without any mortalities. Thank you very much.
Thank you, Dr. Bukhari.
Okay, so I think changing the name and all that is something that we have committees that look into it. You know, we have a group of experts which has a lot of virologists and other experts from around the world, and they will tell us if the virus has changed enough that we need to change its name. So we will continue to follow that. And on your second question, I think I answered it previously by saying that we cannot, I know that many people are saying it's done. Omicron is going to immunize all of us. It's a natural infection, natural immunity. Well, let's hope so, but let's not presume that that is the way it's going to happen. You know that this virus has surprised us. Every time we think we know something, it changes and it does something completely unexpected. The Omicron variant, no scientist had predicted that it could happen. People thought the Delta would, somehow change a little bit. This Omicron came out of the blue.
Yes.
And therefore, I would be very hesitant to make these kind of predictions and be confident about predictions. No, let's continue our surveillance. Let's keep up the measures. Let's work together to come out of this. Still 50,000 people dying every week. So we are not out of the pandemic.
Thank you, Dr. Bukhari. Dr. Swaminathan, I mean, philosophically, we've erected a wall of several billion people vaccinated against the virus, and still Omicron and Delta managed to penetrate their way through that wall. I mean, it's clearly something that we all have a huge respect for. Dr. Sterns-Marin, you had a question just now?
Yeah, but I think it's partially being answered, but I can bring it up again. It's about the question about the virus going, or the situation going endemic instead of pandemic. We have seen several countries stop testing partially and referring to widespread mild symptoms of Omicron, and it spontaneously, my comment is it's very premature just to tell. But do you have you touched the subject earlier, but could you give a comment about this prediction of going endemic instead of pandemic? Thank you.
Yes, Heidi, that is the direction of travel. I think we all agree that we're on the path from pandemic to endemic. But different people understand endemic in different ways. Some people think endemic means it's gone away. It's not a problem. We know that we have many diseases that are endemic, which are a huge problem. TB is endemic, influenza is endemic. We have a lot of endemic infections. So it only means that it settles down into, it becomes part of our routine life, and it settles into, I think, a level at which society can manage it, that we learn to manage and live with it. It does not disrupt our lives. And that's what I think many countries today are trying to get to, that balance, trying to think about how are we going to live with this. And it's good to think about it, because for me, like keeping schools closed for 2 years, I mean, I think we've done so much damage, and we should not think of that as the way that we're going to manage this infection. So there are things that we have to take today on board, things that we've learned, and apply them, and do the ones, like I mentioned, the most effective measures. So rather than telling everybody, take your masks off, let's keep our masks on, for longer. Let's try to limit transmission. Let's each of us do our bit. If we are sick, let's stay at home. Let's not go into work. If you're somebody who can work from home, fine. But there are many people who cannot work from home. They have to get to their workplace. And the sad thing is that this pandemic has affected the poor much more than it's affected. So it's brought out the inequities. And I think we have to keep in mind, what is it going to do to the poor? What's it going to do to nutrition? What's it going to do to diseases like TB and NCDs? And the lack of access to healthcare has killed many people. We were only tracking COVID deaths. We're also now trying to do this estimation of excess mortality. And we know that the true excess mortality is much higher than the reported deaths, and that many people might have died of non-COVID conditions because they did not have access to healthcare during this period. So I think the discussion at the country level on how do we keep our society functioning, how do we keep our health system, and at the same time manage COVID, which is not going away. There could be another variant. What will we do if there's another variant? Of course, we are, I think, in a way quite lucky that Omicron turned out like this, that it has a much less severe disease outcome. We don't know if the next variant will be the same, unfortunately. And this is why it is unpredictable. And so we have to plan for scenarios for the future and have a plan.
Thank you very much. Prof. Arun, you have a question?
Thank you, Dr. Swaminathan, for an excellent session, which has removed a lot of smoke screens. But there is so much of confusion with WhatsApp University. That's why I think such sessions definitely help public. My question is, the monoclonal antibody cocktails, those were working in Delta, do they work in, say, moderate or severe cases of Omicron, or the new MABs to be available?
So Trovimab is the only one that's thought to work on Omicron. Of course, there's more data coming, so that's why we are recommending Sotrovimab, considering that most infections today around the world are going to be Omicron. So it may be a waste actually to use the other antibodies. But in an individual patient, you don't know which strain they're infected with, which variant. But you have to go with the country's epidemiology. So if the majority of cases in the country are Omicron, then none of the other monoclonals will work except Sotrovimab. That's what we know till now.
Actually, I'm very happy because Vaccination is found to be now useful by WHO.
Yes.
But it is the one first drug which was discovered by artificial intelligence. And I think that's why, because such flows, such pathways would help us to find out new drugs, because AI would be coming in. Thank you.
Thank you.
Dr. Chong, do you want to take a couple of questions and then I can try and address them together to save some time?
Absolutely. I think we are short of time, so I would request everyone to just reduce the question time period asking, and also we can have some questions straightforward. We can have a rapid fire if you want. Dr. Chong, yeah.
Yeah. So, Sanjay, do you have any questions for Dr. Swaminathan and Ravi and Alvin?
Yeah, I just want to thank Dr. Swaminathan, but I will say that we have seen so much miseries in last 2 years, and we go forward. But is it not important to look back? Why, what induced this virus in the world? So, is the origin of the virus? Is this not important so that we can at least do something to prevent such type of episode for the society in future?
Okay. Thank you. Ravi, do you have something to ask?
Yeah. Thank you, Dr. Soumya. Wonderful presentation. I am Ravi Naidu from Malaysia. Well, in this country now, the Minister of Health is contemplating or talking about we are going to go into the endemic phase probably in the next 2 to 3 weeks. I would like to know whether WHO has got any criteria for us to become endemic. That's all. Thank you.
Okay, thank you, Ravi. Alvin, do you have a question for Dr. Swaminathan? Can't hear you, Alvin.
Dr. Alvin, you're on mute.
All right. Thank you very much. This is Alvin from Hong Kong. Thank you very much for your excellent lecture. I have 2 questions. The first one is about pediatrics. I am a pediatrician and I personally support vaccinating children. However, of course, there is a much bigger dispute in vaccinating children because children has much less severe diseases in the Omicron as well as in general in this pandemic. And however, the parents are always worrying about the long-term side effects of the vaccination when we are balancing the benefits and the risk for these. Well, of course, we are against those anti-vaxxers, but rationally thinking, when in this world, there are so many places in Africa, especially, the vaccination coverage is really so low. So as a global citizen, and not just a pediatrician, as a doctor, humanitarianly, should we think about the strategy? Are we advocating vaccinating most of the children in the first world when we have to give and take? We should have the emphasis to vaccinate the third world people in that case. So this is the first question. The second question, I don't know, what do you think? In the world, mainly China, well, together with Hong Kong, and I guess perhaps Macau, we are taking the approach of zero tolerance still. Whereas in the rest of the world is all coexisting with the Omicron or the virus. So what do you think? Thank you.
Thank you all. And Dr. Swaminathan, I think those are the last questions for today, and then we'll trouble you to answer them. Thank you very much.
Thank you, Dr. John. All very good questions. Starting with the origin of the virus, absolutely, it's very important to know how the virus emerged, from where it emerged, which was the primary host, and whether there was an intermediate host. This is why we have this committee, the SAGO committee, which is the group which looks at virus origins. And it's not just at SARS-CoV-2, it will also advise on how to investigate the origins of other viruses. We know most viruses, many of the epidemic causing ones are zoonotic and they jump from animals to humans. So, excuse me. So we will continue the investigations, and there is a committee now and work with China to try and find out exactly what happened. This is going to be a process, and I hope that we will be able to find that out. The second was around endemicity and the definition. Yes, I think that's a very good question, but I don't think we have a definition for that or criteria, which probably over the course of the next few months, we should start thinking about. It is very difficult, I think, to establish the criteria, but we will at some point, of course. And I think the point is, at what level do you accept that this amount of mortality or illness can be acceptable and that we can live with? And maybe, influenza could be a benchmark or something like that. So I don't have a good answer, but this is a very good question that will be debated in the coming months. And I hope that during 22, we will move from pandemic to endemic, but again, can't be 100% sure about it. On children and vaccination, very important points that you've made, Dr. Chan. It's, as you mentioned, it's a question of benefit versus risk. And this is why we have this grading for countries to think about which groups need to be vaccinated. Ultimately, if we want to prevent transmission, we want to also, of course, protect children, because even though this is a very small proportion, there is a small proportion of children who get severely ill. There is a very small proportion who get the multi-inflammatory syndrome. And then, of course, there's a tiny number who die. But if we can prevent that through vaccines, why not? So I think the primary course of vaccination going down to children, the age of 5. There are some vaccines that have been tested down to the age of 3, the inactivated vaccines, but WHO has not made recommendations on those. At the moment, it's only the Pfizer that has a WHO recommendation above the age of 5. So we need more data on the others, and then obviously we will extend the age range. So yes, for a primary course, it could be justified. But at the same time, what you mentioned, very importantly, we have said repeatedly that we encourage countries who have finished vaccinating their high-risk groups before they go into children, please share the vaccines so that other countries can vaccinate their high-risk groups. In many countries in Africa, even 1% of their population has not been vaccinated, which means healthcare workers and the elderly have not been vaccinated. So we have made that from the beginning, that request. And even when countries started doing boosters, we said, okay, do boosters for the high-risk groups, but please don't start boosting everybody, because there is no evidence right now that we need that. Let's first protect people around the world. So the equity issue has been something we've championed, but it's been an issue, it's been a problem for us. And I hope in 22 we can improve on that. But again, that needs global solidarity, as we have been saying all along. But thank you very much. And it's been a pleasure to be with you all today.
Thank you, Dr. Swaminathan. Most thankful. Glad you could make time for us.
Thank you. So we would like to end this session. I would like to invite Dr. Veena for closing remarks and thanking Dr. Swaminathan, and then we will close the session. Dr. Veena.
It was an absolute delight to be listening to you, Dr. Swaminathan, and getting more insights through all the various questions that were asked by the various country representatives. And these are all the problems that we are also facing in India, especially for the school children not going to school. The principals are just sitting there, the teachers are sitting there, and there's kind of a hysteria amongst parents not wanting to send their children to school. So we are looking to addressing that through various campaigns through a foundation. And it's been a delight, and thank you so much. And I hope that you will be available to us and be graceful enough and kind enough to come to our platform again whenever we need you. Thank you so much, and all the very best.
Definitely. Thank you so much.
Thank you. Thank you everyone for this wonderful session of 94th episode. We are closing today. We will be live again next week, same time. Sorry, it's the same day, but it will be 9:30 a.m.
Yes,
Thank you very much.
Thank you so much. Thank you, everyone.